So, good evening. First of all, I would like to thank Jorge, not for the invitation only, but for taking the time and the effort to organize all those events, which I hope our patients enjoy. Second, I would like to thank you all for spending some time within your valuable Friday evening. Come and listen to us. Today, I'm not going to go through again my usual talks about everything. I'm going to focus on what's new. And as usual, while I'm doing these meetings, I don't want to give a lecture. I do want to be interrupted. I do want you to ask me questions. I will stop. I will go step by step. I will ask you whether it's clear what I'm saying, whether I'm using medical jargon. My slides are medical, but my language will be as simple as I can. Okay, but please do interrupt me if you need to ask something or something is not very clear to you. Okay, agreement? Good. So, is one of my classical slides that I present to various audiences, saying that even if you forget anything or everything about NETs, neuroendocrine tumors, carcinoids, whatever, I want you to remember those 5 things. And in that box, in the past, I had put the word rare. I delete the word rare because the incidence is really rising and the NETs are not as rare as people were thinking. So I replaced this word with the word heterogeneous. Does it make sense to you, the word? Heterogeneous means that this tumor can consist of many different things, many different aggressive type lesions or low-grade lesions, but overall, this tumor cannot be the same in every part of your body. Okay. Those tumors, second feature is that slow growing usually. Those tumors may secrete hormones, causing symptoms such as carcinoid syndrome, flushing diarrhea, carcinoid heart disease. These tumors may have hormonal receptors on the surface, and luckily, those tumors can be treated by more than one option, which is very good for patients. Clear? These are the 5 up-to-date features of neuroendocrine tumors in general. The tumors consist of cells, and we've got already those cells in our body. Those cells, the neuroendocrine cells, are forming glands. For example, the thyroid gland, the pancreas, the adrenals. But also those cells are diffusely distributed in all the lining of our organs, but mainly in the pancreas, the stomach, and the gut. And this is why the majority of those tumors are located in our digestive system. Make sense? Because normally those cells are found in those areas mainly. Now, let's talk about location. You see the incidence of the primaries in various parts of your digestive system: stomach, duodenum, appendix, small bowel, rectum, colon. What you see in the last sentence is that some of those neuroendocrine tumors, up to 10% of them, the 10% of them, can coexist with other cancers. So we see patients having breast cancer, colon cancer, and at the same time, they can have a NET. Pancreatic neuroendocrine tumors can be also linked with some genetic syndromes. First comment here. If patients are worried about families, those who need to worry mainly on what we know so far is those with pancreatic neuroendocrine tumors, not with other NETs like small bowel, stomach in general, but those with pancreatic NETs. Those tumors can be familiar between 10 to 30% of cases. We find it out very easily at the beginning by doing some screening blood tests. And if this blood test makes us suspicious, we send the patient and his family for genetic testing. Okay, but this at present applies only to pancreatic neuroendocrine tumors. I would like to make it clear because patients come to clinic quite often and say, I've got a small bowel NET. Can it be inherited? Can I pass to my children? On the basis of what we know so far, there's no strong evidence. Well, in the future it may change, but on the basis of what we know so far. Clear everything so far? Good. There are some other neuroendocrine tumors outside of the digestive system. For example, in the thyroid gland called medullary thyroid carcinoids. In the lungs, called bronchial NETs, or in the gland called thymus, called thymic NETs. And in the adrenal glands, can you appreciate that this is Robin Hood hat, and this looks like the adrenal, So this is how the adrenal looks like. And these are rare NETs, not related to the digestive system. But we've got quite a few patients with those NETs as well at Royal Frame. Patients, friends, and colleagues who have watched my presentation before know this slide quite well. And I always refer to people who like the old-fashioned Westerns, the good, the bad, and the ugly. But I find it as a very good example to identify and make you remember the three main types of aggressiveness of neuroendocrine tumors. So we've got the good group on the top, which is either benign or has got a low-grade malignant behavior, has got low chance of spread. The B group, please. I'll come to that. So the ugly group, which has got a higher, more aggressive potential, and the very ugly group, the C option, which practically behaves like common cancer. So how we make this distinction? On the basis of two features. On the basis of how the cells look like, and on the basis of a marker called Ki67. This marker shows what? Very simple. Shows how many cells of what we see has start proliferating out of 100 cancer cells. So the histopathologist who look on the slides, he looks roughly on 100 cells of cancer and see how many of them, percentage, start proliferating. So on the basis of this marker, we can divide. Can you see the category B, that starts from 2 to 20, is a very broad spectrum. So this is a gray area to see whether this could behave towards number C or number A. So towards high grade or towards low grade, depending on how high is that marker. Makes sense now? So if your doctor in clinic talks about low-grade tumor, he means that the Ki7 is below 2%. Please.
How much is it judgment? Can you repeat the question? Yes. How much is it the judgment of the hematologist or histologist who's looking at the cells? Because I had some done first and some done here, and there was quite a difference in the Ki67.
That's a very good question, which gives me the opportunity now to go to the term heterogeneous. Advance in that medicine now. Be careful, this is very, very important point. We've seen two different Ki67s within the same tumor lesion sometimes. And we've seen different Ki-67s from the primary tumor, pancreas or small bowel, and the liver metastasis. I will show you a slide. So this was not necessarily a mistake, but because the material they sent to us was not exactly the same than the slide they kept for themselves. This is, dear friends, very important information to remember, to make some assumptions about the long-term behavior of those tumors. Because you may feel very relaxed, or we as doctors may feel very relaxed, that the tumor is low grade from early beginning, but then, at some point, it behaves very aggressively. So we are quite puzzled. Why? Now we know. We know, and I will tell you what we can do. And here we are. Can you watch this diagram? You see the Ki-67 of the primary, here, almost 2%. And this is a liver resection. So they resected a liver containing 11 tumors in the liver. Can you see the difference? So from practically 0 to 25%. So the liver contained 11 different tumors. This demonstrates the heterogeneity. This, though, does not happen in every patient. And how we can guess, how we can predict, how we can identify? We can. By looking on how the tumor behaves in the scans. For example, if the tumor has been stable throughout the years and the patient is well, most likely all of the lesions are low grade. If, for example, the patient has got 6, 7 tumors in the liver and 2 of them play a naughty role, these 2 lesions may be slightly more aggressive. How can find out? By doing a relevant PET scan, I will show you, or by biopsy those lesions. And then we amend our management towards a more aggressive behavior, our behavior, medical behavior. Make sense? This is something that not many doctors in the world that see NET patients know. So you need to have real experience in NET medicine, and please do feel relaxed that you are a patient of Royal Free. Okay? So, how we make the diagnosis? And also, what are the advances in our diagnostic process? Remember the simple 4 steps. First of all, medical school knowledge, take a good history and examine the patient. Second, request some relevant blood or urine tests. Third, pick up and request the most appropriate scan. And finally, always rely on histology. Biopsy. You cannot make the proper diagnosis without a biopsy. You need a biopsy, more or less. Okay. Now, I will describe what's new in every step of those. For the very first step, history examination. Unfortunately, so far, we have not found the magic symptom that can tell to everyone this patient's got a NET. So, the only weapon that we've got is to increase awareness among physicians. And we, as Royal Free, nationally and internationally, giving various talks, deliver lectures, sharing information, and make physicians aware that it is not irritable bowel syndrome, it's maybe a small bowel NET. I've spent hours lecturing in UK and abroad, try to give them at least the symptoms that can make someone think that it is IBS. Because IBS, irritable bowel syndrome needs some criteria, simple criteria. But if it's not IBS, think out of the box. Take a careful history. Spend some more time. We are in a much better situation, I have to say, than a few years ago. And with international campaigns, NETs are becoming more fashionable in diagnosis. Next step. Biochemical tests. You are familiar with chromogranin A, and I can recall quite a few of patients coming to clinic asking us, "Doctor, what is my chromogranin A levels?" On the basis of many studies, retrospective studies and prospective studies that we've done here at Royal Free and in the literature, we now have learned not to rely so much on this marker. It's a good marker because it's the only one that we got for general assessment of neuroendocrine tumors, but we cannot make decisions on the basis of this marker. I will give you an example that I give to patients later on about the windows and the room. Remember that. So this marker that we still use, the new information is that it's not as sensitive and as specific as we thought a few years ago. The new thing about the urine test is that patients now, hopefully soon at Royal Free, will not need to carry the plastic bottle for the urine, carrying the explosives in the train, the explosive liquid, but we can do possibly the same thing by doing a simple blood test on the day of the consultation, which is a real revolution because now we are having more and more data stating that plasma FHA levels are as good as urinary ones. More convenient though, eh? Now, we are very proud of this marker, and this is called NT-proBNP, because this is a screening marker for carcinoid heart disease. For the friends who are not familiar with this, carcinoid heart disease applies only to patients with flushing and diarrhea, carcinoid syndrome. And what it is a development of scarring in the valve the valves of the heart. Okay? So it does not apply to any other patient with stomach net, pancreatic net. Okay? So it applies only to those patients. The gold standard, obviously, is the cardiac echocardiogram, the cardiac ultrasound, but on the basis of our studies, we found that this marker in the blood can make an early diagnosis. This is Royal Free studies, and we have now more studies confirming our results. And I'm also very pleased to say that hopefully in the next few weeks, we will have the first internationally published guidelines ever for carcinoid heart disease with collaboration of Europe, Mayo Clinic from the States, coordinated by whom? By Royal Free. So this international network, which is going to produce the very first published ever guideline paper, is coordinated by Royal Free. Now, another Royal Free innovation is the development of this marker in the blood, which is simple and looks simple. It estimates circulating tumor cells. The tumor occasionally releases some cells in the circulation, not always, rarely, but with special devices, we are able to pick them up. And you may say, so what? We have found in the very early studies that even one cell in the circulation may indicate a more aggressive behavior, even in low-grade tumors. So that test is quite clever. And this year, we published a paper, demonstrating what is the implication to the response to treatment if we find cells throughout the treatment course. And you can see that patients who had, for example, more than 8 cells in a period of 3 to 5 weeks after treatment in her blood, they progressed quite quickly, despite treatment. Have we found the miracle? Not yet. We need more studies. We need to validate this marker with other centers around the world. But we think that we are offering a very, very good tool for the future. Circulating tumor cells. Are there any other markers in the world that can serve towards that direction? Potentially, yes. And the team from Yale University are calling this marker tumor's fingerprint. What I'm talking about. So they found a marker which is based on 51 genes in the blood that can identify a recurrence of tumor after an operation. For example, you get your tumor resected, and then all the scans show no disease recurrence, nothing. They think and they feel, on the basis of their results, that if you find this test positive, this could be an early marker of recurrence even before the scans. Or if this marker in the blood goes up towards the course of treatment, this will predict a non-response to treatment. So another good tool in our basket. Circulating tumor cells and this test which is called NET test. Yale University offered us collaboration. I presented some results in the States in May, and they approached me and they offered collaboration for us sending bloods to them from our patients. So if in the future we ask patients in clinic to collaborate with us, please be positive. So, moving from the blood and urine test to the imaging. And before I spoke about receptors, imagine that the tumor is a cake, and those flowers on the cake are the receptors. And this is a bee. You can see that. So these are hormone receptors, and this bee is what? Is the monthly injection, who goes there every month, get attached to the flowers, but what happens then? The flowers are sucking the bee into the tumor. We call those drugs agonists. So the drugs that can be attached to receptors but then get internalized. Remember the word agonists, because I will come with something different very shortly. So the presence of those flowers and the bees is the basis of treatment with a monthly injection, but also the basis of visualizing the tumors with this very modern PET scan, which you are familiar with, some of you, the gallium-68 PET, which is superior to the octreotide scan that many patients had before, 2 days spent to the hospital. So this PET scan, which is now established, very well established in our practice, in a few years, we feel that it will replace completely octreoscan and does not have only the advantage of convenience, because it can be completed within 3 or 4 hours, but also it is much more sensitive and specific, because it can pick up lesions as small as 5 millimeters. Whole body scan. The other form of PET scan that normally is used for more aggressive cancers, called FDG PET scan, is useful in tumors who belong to the ugly group, the more aggressive ones. And also, be careful here, we can use it in combination with a gallium PET scan to pick up potential tumor heterogeneity. So if, for example, two of the tumor lesions behave more aggressive in the CT scan or MRI scans, then we can do a gallium PET, which can pick up the low-grade ones, and an FDG PET at the same time to pick up the aggressive ones. And this is an example here. It's the same patient at the same time, not with two different tumor grades, but with two different cancers. On the left-hand side, you can see a gallium PET scan. You can see this hot, red. You can see this is blue, is cold. So this is neuroendocrine tumor, but what is this next to this? Something else. In the FDG PET scan, just the opposite happens. So the cold lesion now becomes hot, and the hot lesion is now blue. So this patient had liver tumors next to each other of two different cancers, the neuroendocrine and the bowel cancer. And we found this through the PET scans. Combination, please.
Are they using a different molecule to attach the gallium-68?
Yes, because the gallium PET is using the receptors of the cake, the somatostatin receptors, and FDG is using a different totally isotope. Yeah? So without being invasive, by combining those two PET scans, we cannot pick up a different cancer, but we can pick up a neuroendocrine tumor with two different behaviors at the same time, the same patient. Make sense? Now, for the heart, we are having this new cardiac MRI, which in some patients and some valves can be superior to the echo, the ultrasound, by identifying properly how much the valve has been damaged. And we use it as required. And now the future. The future which hopefully will start shortly in the next few months at Royal Free. You remember what I said to you about the cake? The cake, the flowers, and the bee that gets to the flower, but then gets sucked into the cake. And this was the agonist. Now, the new drugs may be antagonists. What the difference? They will come to the flower, hit the flower, get attached to the flower, but never go in. And early studies have shown that the antagonists may be better in demonstrating the tumor, but also in treating the tumor. So for the magic bullet, for PRRT, we've been using agonists, the bees that can get into the cake. We are starting trials shortly with these new drugs, which are antagonists. So you can see that higher dose we get to the tumor than to the kidney, for instance, which is a side effect of PRRT, of magic bullet. So with these antagonists, we are getting more radiation and more drug to the tumor, and which can give us better results for imaging and for treatment. And this is something really brand new. Please. No. The clinical trial that we're starting excludes patients who have PRRT already. So we need now naive patients, patients who did not have PRRT. So we are planning a trial at Royal Free in the next few months or weeks, depending on how quickly we can set up things, for patients who did not have PRRT, because we need to see prospectively what's going on, and then we can develop a new group, perhaps with patients who had PRRT before and did not respond. Okay. Now, in the future, we will look like this, the physicians. With all these modalities, circulating tumor cells, the fingerprint, the PET scans, we hope that we will be able to tell the patients from the early beginning how the tumor will behave longer term. And this will be a real revolution. Because so far, we rely on how is the patient, the age, the comorbidities, the tumor load, how much tumor the patient got in his or her body, the grade of the tumor, low grade. But if we have the magic ball that contains everything inside and give us a mathematical model to tell us a score, for instance. This is our ambition. Jorge knows that. From the early beginning to tell us that if the score is above, for example, 10, this patient needs more aggressive treatment from the early beginning. Makes sense? And this is our ambition. We'll get there one day. Yes, for sure. Yes. So we are now gathering information and identified already with Jorge's help. We analyzed last year 600 small bowel NET patients, and we found some predictive factors, clinical factors at the diagnosis, but this was retrospective. So this gave us some clinical tools, but we need some other tools. The new markers, the PET scans, the antagonists. So we need everything. Make sense? Any questions before I move to treatment? Okay. Classically, and this is our philosophy at Royal Free, the main concepts of treating patients are the following four, the main targets. First of all, medically control patient symptoms. Second, to see whether we can resect the tumor, primary, and if possible, the spread, the metastasis. If this is not possible, then we need to find ways to control tumor growth, to prevent spreading. And overall, we need to put all our efforts to improve and maintain patients' quality of life. And for some patients, quality of life is to enjoy their favorite sport. So, I've got many patients in clinic who sometimes, have got some non-realistic expectations. But it's not the patient's fault, it's our fault. So the physician, in the very early beginning, should set up the objectives of treatment. And there's a different philosophy between neuroendocrine tumors and other cancers. And I share this philosophy with my oncology colleagues whenever I give talks. I say to them, dear colleagues, please be sure that you are not more toxic than the tumor itself. Why is that? Because neuroendocrine tumors are slow-growing malignancies if they have spread. So to try always to shrink the tumor and to shrink the tumor and to shrink the tumor, you may end up shrinking the patient overall. So NET patients should understand and accept that stable disease with no symptoms is a very, very good outcome. Make sense? So patients with NET tumors should not get disappointed if the tumor after treatment has not shrunk. They should be pleased to hear that the disease has been stable throughout the years and they are well. And these are very good results of treatment. Is it clear? Good. So, for the first target, control of symptoms. This looks complicated, but it's not. So this hormone is a hormone that mainly is responsible for carcinoid syndrome, serotonin, flushing and diarrhea. Okay. So far, the monthly injections do what? Try to inhibit the production of tumors, hormones, and tumor growth by attacking the flowers. What about finding something more clever and blocking the chemical reaction which produces that hormone? And this is here. It's very simple. There's a drug, oral drug, called telotristat, which again is blocking this enzyme. What more clever than that? So it does block enzyme that produces serotonin, and therefore we expect that carcinoid syndrome symptoms will subside. Make sense? Theoretically. Indeed, this drug was checked versus placebo for management of carcinoid diarrhea. Be careful. Not every diarrhea. Diarrhea that is due to hormones. And the results were quite impressive. So you see, with this dose, 500 milligrams 3 times a day, patients experience reduction of at least 35% of diarrhea on a daily basis. We have not got results about flushing as yet, but we hope that this new drug, when it becomes available, in combination with the injections, because again, this drug does not work on the tumor growth, works only on the hormone. So drug plus monthly injection will help us patients who have breakthrough symptoms, diarrhea, let's say, to feel much better. So this is an advance in medicine. Second advance in medicine is something related to the tumor growth. This drug, called Everolimus, which was used successfully in patients with pancreatic neuroendocrine tumors, has been demonstrated to work also for other neuroendocrine tumors, such as those of small bowel origin. And it was tested versus placebo, and what it happened, it achieved prolongation of progression-free survival. So it makes disease more stable throughout the period of the years. Be careful, does not work on symptoms. So if a patient has got more symptoms and more tumor growth, this drug will help only for the tumor growth. What helps for both? PRRT. PRRT, that you're familiar with, has been proven this year by Royal Free that works in patients with refractory carcinoid syndrome. And we're the first group in the literature that proves that patients who have refractory flushing and diarrhea and have PRRT achieve a good response on symptoms. And not only this, a study that was announced in autumn 2015 demonstrated that PRRT does work for tumor. We knew that. How we knew that? On the basis of retrospective studies. Now, this study has challenged PRRT against high dose of injection. So patients who are progressing tumor-wise on the monthly injections, half of them received a double dose of injection, and the other half received PRRT. Can you see the two curves? The green curve is favoring PRRT. So we now have strong evidence that PRRT, the magic bullet, does work for symptoms and for tumor, especially in patients with advanced small bowel neuroendocrine tumors. So you may ask me, why they stopped this funding then? Why they don't fund it anymore? That's a good question. To conclude, whatever we do, whatever we change, whatever we learn, we should share it with our peer colleagues. In the tumor board meeting, we call it MDT here. So this is the first MDT ever. This is the first group in Mount Sinai Hospital, New York, who made the first renal transplant. You see how many physicians are putting down their egos and sharing their views on the basis of the same X-ray. And this is exactly how an MD works. So we put down our egos. We are ready to challenge or to be challenged, in our opinion, because by the end of the day, our target is to get the best individualized treatment for each particular patient at the best particular time. And to achieve this target, you cannot be alone. This is Royal Free MD team. We are very proud to have one of the best MDTs, and because this will be public, I can tell it, this will be on YouTube, I can tell this clearly, that this is one of the best MDT teams worldwide, and I insist, and I can prove it. And with this, I would like to take you to the take-home messages of our talk. So, what's new? Increased awareness of GPs and other doctors will facilitate early diagnosis of NETs. NETs now are really heterogeneous, and now you know what does it mean. Chromogranin A is not the ideal marker. 5-HT now can be measured in blood as well, so we don't need to bring the urine here in the future. NT-proBNP is a very good marker for carcinoid heart disease. Circulating tumor cells and the fingerprint are promising novel markers for the future. The antagonists, you remember the antagonists now, are a promising tool for diagnosis and treatment. New oral agents and the magic mullet seem promising for controlling of symptoms and disease. And PRRT and Everolimus seem to effectively control tumor growth in small bowel nets. And with this, thank you very much for your attention.
Thank you so much, Christos. It's such a pleasure to hear you, to make it so approachable, so easy to understand, you know, something that is quite complex. I'm sure that there are some burning questions here. Okay, now it's your time to grill Christos with questions.
Not a question, this is a punt. The 10th of November is World NET Day.
Yes.
And the NET Patient Foundation are looking for volunteers to man tables at all the hospitals so we can get the voice out there, the message out there about NET, to broadcast it to doctors in the units, to broadcast it to other patients, and just to get publicity, to let people know that NET is a disease that is treatable and is out there.
That's brilliant. May I allow to make any comment about this? So my comment is that the NET patients are the best ambassadors of NET disease. So you are the most precious collaborators of us by increasing awareness in this country, at least. And last year, on the 10th of November, we released a video about 3 new treatment options for NETs. It was Prof. Kaplan, myself, Prof. Meyer, and Sona Knavalkisur, the nuclear medicine physician. And you may recall that I did an online questionnaire. This year, sadly, all of us will be in Europe. We have the annual advisory board of the European Neuroendocrine Society. So on that, I think it's Thursday, we'll be in Munich with all our peers, the NET experts from Europe, 60 people, discussing the future. So we'll not be able to do something here and then on that day, but we are open for ideas, share with you your ideas. if you have something to offer, to plan, we have 2 months to plan, you're more than welcome. And we can ask for help locally from the Net Patient Foundation, Jorge. Yes, so we need, dear friends, we need to make noise. Noise, noise, noise. Otherwise, the net cancer is always underestimated. Who cares? Prostate, breast, colon, lung, who cares about net? No, we need to make noise, and we do need your help, please.
Just to say that I had a stand at UCH last year on the 10th of November for Awareness Day. I work at UCH, and it was really interesting because I didn't even know we had a paediatric net team at UCH, which I wasn't aware of. And a couple of the nurses that I've known for years, I found out their husbands had net like mine. So it was really interesting that it was a good turnout of people, and we also raised loads of money too. And I think just out to your local hospitals, which are more important than some of these big teaching hospitals, because they're just so unaware.
Brilliant.
Thank you.
Please. Yes. Just wait for the microphone.
I was just going to ask you, will this Brexit thing affect your relationships with Europe in the medical profession?
It seems to affect the academic funding, because quite a few of the academic programs from universities, and I know about UCL because I've got quite a few friends, were linked with European funds. We may have some issues, but I can tell you something. Personally, what I feel, that medicine, academia, research are far above all politics. Medicine will find a way. Medicine has found its own way since Hippocrates. Medicine was attacked by various people, and knowledge was attacked by various people. So I don't think any politician will be able to attack research, medicine, and academia.
I also wanted to say that a way of raising awareness, which is a strong weapon towards raising the profile of neuroendocrine tumors and better diagnosis, in the recent issue of our newsletter that it's on the table, there is also an article regarding on how to become patient ambassadors. You know, because this is like collectively voicing the people together, you know, instead of like doing like in isolation or one by one with their own individual problems, which are very important, but as a collective, you can influence research, you can raise your voice, and it could be heard more loudly. So if you're interested, there is some steps on the article of how to become one of those. Thank you.
Jorge.
If serotonin 5-HT is the main source, and some of your systems work by inhibiting the production of it from tryptophan, does that mean we should all be avoiding anything that has tryptophan in it?
That's a question that I've been answering many times in clinic. So whether you can avoid things, it's not so simple. Patients also said, should I avoid foods that contain serotonin? No, doesn't make sense. But we need tryptophan, definitely, to produce other very essential elements of our body, like vitamin B.
So it's the swings and roundabouts.
Yeah, so we need to have, because the body will find ways to produce serotonin still, but also we need tryptophan. We need tryptophan to produce vitamin B. So it's not a good idea not to eat foods that contain tryptophan, the amino acid tryptophan, because you will become with a disease called pellagra, with a very dry and very bad skin, at least. So let's block the serotonin pathway, because in carcinoid syndrome, what happens, the majority of tryptophan becomes to serotonin, and that's why some patients come to clinic with itching, and some of them have vitamin B strong compound. That's why. So we try to give them vitamin B because they're underproducing. So the whole tryptophan goes to serotonin, and only a little bit goes to vitamin B. So by blocking, for example, the serotonin pathway, we hope that the other angle will start working mainly. So it doesn't make sense to stop tryptophan. Pleasure.
Yesterday, we were trying to book a short holiday to Spain, and I contacted my insurance company to take out an insurance. And the insurance company flatly refused to cover my wife because they had never heard of NET. We tried to explain to them, but they just said, no, you are not covered, and we just never heard of that illness. Is something being done to make insurance company aware of this illness?
Yes, to my knowledge, I don't know, Jorge, what's you, it's not a medical question, but to my knowledge, the Net Patient Foundation has got some solutions for this. So if you have got any other?
Yeah, we did like a monographic on insurance that they were friendly for NET patients. And they were also, we had like an open discussion once in here, like maybe a year ago. And a lot of patients gave us a lot of information of insurance brokers that they were like having a very good quote. That
for NET patients?
For NET patients.
Okay,
yeah,
so, and this information available where?
Yeah, this information is available on our website.
Okay, perfect.
And also in the Net Patient Foundation. So definitely something that we can give you.
So you can then tell them, if you cannot cover us, we can go and look somewhere else.
Yeah. I
Simply.
think one of those is
so simple.
It's coming to my head. It's
Yes.
called Insure Pink. That was one of those, but there were like 3 or 4.
Yes.
Yeah. Any more questions?
So have I had my last urine collection 5-HIAA, or can I expect the blood one next time?
We are trying to work closely with our biochemical department because we don't analyze this in our office. We need a biochemical department to set up the kits. So as soon as we get ready, we will share this with all of you, definitely.
You spoke earlier on about the acceleration of a tumour, and I was wondering, when a tumour gets bad, what sort of symptoms would we sort of experience? What would you experience when a tumour changes?
Depends definitely on the location of the tumour. That's why I described, if it's in the stomach, for example, you may have significant stomach ache, nausea, vomiting, weight loss. If it's in the gut, it may obstruct the lumen, think like a plumber. Eh? The small bowel is like a thin tube. If the tumor starts growing inside the lumen, the patient develops bowel obstruction. Okay. If the tumor is growing within the large bowel, like bowel cancer, the patient can have blood in the stools. So depending on where it is, you should expect relevant symptoms.
So at what point would you consider it necessary to take biopsies from metastases, because you showed the frightening graph of variation?
Absolutely. So if the scans, CT or MRI, that we do every 4-6 months, once a year, show that all the tumors in the liver, let's say, apart from 1 or 2, are stable, behaving like low grade, but 1 or 2 start behaving badly, then we do an FDG PET, the PET that covers the aggressive nets, and if this shows hot uptake in those particular 2 lesions, we put a needle and take biopsies. Because there are 2 theories. Either a low-grade tumor became higher grade throughout the course of the disease, one theory, or the second theory is that this particular tumor spot was aggressive from the beginning, but it was behaving like slowly, initially. Okay?
I have a question for you. I think you said that the antagonist medication with PRRT increases the amount of radiation into the tumor.
Yes.
wouldn't that increase the amount of side effects or toxicity?
No, because the studies that are measuring the dose in the tumor in the kidney show that, let's say that we give 10 kilograms of radiation with classical PRRT and 10 kilograms of radiation with the antagonist PRRT. So with classical PRRT, let's say that 7 will go to the tumor and 3 will go to the kidneys. With the new antagonist, we are expecting that 8 or 9 kilograms will go to the tumor and 1 only to the kidneys. So these are the preliminary results. That's why we do trials.
Another question.
Please.
You said that the circulating tumor cells, even if there is one circulating through the blood stream, it could be an indication of bad prognosis.
Yes.
When the circulation tumor cells assay is going to be available for the prognosis of neuroendocrine tumors?
In order to convince a big company to buy the project, invest money, and make it available, this process will take some time because, again, this needs to be validated. For example, the fingerprint test currently, for the cost of the lab that is doing it in the States, is cost $3,000 per test. So they spend their own money for each particular sample, each particular test. So it's impossible for any health system to support a marker that costs $3,000, let's say 2,000, how many pounds is that? Whatever. Yes. It's impossible. And to be measured once or twice a year, let's say. So we need to make those markers as attractive as we can, to sell them to a company that can make a chain of production, and then give it to the market in a more competitive price. So this can be available and funded by the health systems. But this will take years, I can tell you. So those markers at present will be only available through clinical trials.
Is there any more questions? I have one more.
Please.
What's going on with the PRRT? You know, like, it seems that with the evidence that you are showing us today, there is no doubt that it's able to control the symptoms and also is able to control the tumor growth. And before we had that information, this treatment was available in England. And now that the evidence is available, this treatment is not available. And I'm wondering, what is the status of this?
If you are interested, let me get you a little bit of the journey of funding of this treatment. When I first came to UK in 2005, for a good 4 years, the treatment was funded quite easily. For 3 years, between 2009 and 2012, we were really struggling to get it funded, but in some particular patients with some strong indications, eventually, we had it funded. From 2012 until 2015, to get it funded was a piece of cake. Just fill a form, and within a day, we got it funded. So now we get, even we fill 1 million forms, and we make the strongest statement, they reject it from the beginning. I think that people who made those decisions were not net experts. And they used some mathematical, economical models that gave them the impression that this treatment is not cost effective. So it's the mission of the net community to go back to them, and we are going to the NICE committee, National Institute of Clinical Excellence, with good argument to say that, look here, dear friends, this is really good, not for those reasons that I briefly discussed, symptoms or tumor growth, but also it could be cost effective because it reduces admissions, many things that can the patient have. So in the new era, fortunately or unfortunately, we as doctors need to face businessmen and finance people. So we'll get there.
Is there any more? Okay, one second. No problem. This is the time, yeah.
The PRRT is brilliant because the progression is now really nice and stable in my husband's liver, but he's nosedived in fatigue, as you know.
He's?
Nosedived in fatigue. It's worse than it's ever been. Fatigue is always bad, as you all know as patients, but it's the worst it's ever been. And we were warned that, to be expected, the fatigue would get worse. The last 3 months has been the absolute worst. He couldn't come here today because his fatigue's so bad. You say about quality of life, PRRT is brilliant. The scans are coming back really good. It's not reduced the tumour growth, but it's stable, and that's the best we could ever hope for. But in terms of quality of life, it's very, very poor. And there's nothing as a team that you can offer him to help him.
I have to say, every patient is different. Because on the contrary, I can tell you stories. For example, when I first came to UK in 2005, and I heard that we're treating patients with PRRT, I said to them, to my fellows in the team, I say, so what? For me, it looks like an octoscan. What is treatment? But when I first saw a 28-year-old lady, girl, who was bedbound, and she went back to work after PRRT, then I changed my mind. So, unfortunately, every patient is different. And I appreciate what you're saying a lot. So, and I say to the patients that it's a strong radiation treatment to your body. It can make you worse before it makes you better. Makes you better means symptom-wise, Not talking about tumor growth. So, again, I cannot predict or anticipate how long it will take for him to recover from fatigue. It may take longer than other patients, but it will get there. Okay, so again, every patient's story is different, and we rely on what we pick up from the questionnaires and what we see and what we hear from our colleagues, peer colleagues internationally. But overall, and not only myself, it's the quality of life questionnaires that we give. Overall, we make patients better. But definitely, I accept that some patients do feel worse for a period after each cycle. Yes.
I just want to say that I had the treatment 8 years ago, and I played tennis 3 days after the treatment.
Which treatment are you talking about?
This one, didn't I? Yeah, I did.
PRRT.
And I played tennis 3 days afterwards. And I've had a great 8 years. And I had a horrible time before the treatment. So it really has worked for me.
Yes. But I mean, again, every patient is different, but we anticipate some difficulties.
Any more comments?
Carmen?
Hello. My doctor wants to go through my medication with me. And she had put a red tick against my injection. I'm wondering why.
What's she put?
A red tick. You know, she put a red mark against my son-in-law.
Why is that?
I don't know. So she's going to discuss it with me over the phone on Tuesday.
For what particular reason?
I don't know. She said she wants to discuss my medication with me.
Okay.
Yeah. So.
Okay, let's change the question. What would you answer to your daughter?
What would I ask her?
What would you answer back if she says to you that your injection is not working?
Yeah.
What would you say to her?
I'm going to say, contact the Royal Free.
But as a patient, what would you say about the injection?
This injection, it's 10 years I've been on it.
So,
look at me.
Karen is one of our patients who has not had any other treatment since diagnosis apart from her monthly injection. And the tumor has been stable for the last 10 years.
10 years.
So you belong to the very, very good group.
Exactly.
So to stop something that's been working
Every 3 weeks?
I wouldn't do so. I would not recommend, and I would not make any further comments.
Yeah. Well, if she said anything to me about that,
fine.
I'll tell her to contact you at the Royal Free.
Fantastic.
Yeah.
Your doctor prescribe it?
Yes.
It might be that, Esther's doctor can't prescribe it anymore. She gets it from healthcare at home. Yeah. It's delivered every... Yeah.
Okay.
And let us know.
Thank you, Jorge. Dr. Christos, it's really just, well, like all questions, they're of interest to us individually. This one is to me, and I'm sure others might find it interesting as well. During my time of, or post, when I was diagnosed, that's the word I'm looking for, I was at work and I continued to work after diagnosis. I work with students, and at times students of a particular type can be confrontational, and I found during these situations that I would flush. What is it, just for my own interest, was causing this flushing? I've done some cigarette packet research on the internet, and epinephrine is a chemical produced, I believe, from the renal gland. Could that have been?
Definitely. So this question applies personally to every patient who has got experience with carcinoid syndrome. When someone can flush. When they get excited, when they get anxious, when they sip alcohol. When we get excited, our Robin Hood glands, the adrenals, produces adrenaline, epinephrine, and this hormone can trigger the production of serotonin by carcinoid tumors. So it's make the tumors angry. And this is a very clear explanation. So, I mean, what you could do, or someone do, before we give a lecture, when we do something that makes us excited, you can, 2 or 3 hours before that, you can do self-injection of subcutaneous octreotide. This will reduce the amount of hormones because the drug will do a plateau in your blood around that time. So even if you try to secrete serotonin, the octreotide will have blocked acutely that secretion. Any more questions, please?
Okay, well, let's give an applause to Christos.
Excellent.
Thank you so much.